we've got this tremendous expertise here in the room this afternoon, this sort of trinity of expertise. And I'm not quite sure how you really would like to play it. It's your session. But if you could start just by introducing yourself so it's on camera, so that we, when we come to put all together the evidence that we have, we know who we've been talking to. So would you like to start?
Okay. Would you like me to tell you a little bit about how I became involved?
No, if we could just have your names to start with, could we?
So I'm Jill Clayton-Smith. I'm a clinical geneticist, and I work at Manchester University Hospital's Foundation Trust. I've been a clinical geneticist for over 30 years now.
Thank you very much. Yes, Rebecca.
I'm Rebecca Bromley. I'm a neuropsychologist, so I'm interested in how brains develop and function, and I work up at Manchester, half-time at the university and half-time at Royal Manchester Children's Hospital.
Right, thanks very much.
And I'm Peter Turnpenny. I'm a clinical geneticist working in Exeter, where I've been for 25 years.
Thank you very much indeed. Now, you want to say a bit more about yourselves, did you?
I first became interested in this whole topic of the effects of anti-epileptic drug exposure in babies in the early 1990s. And that came about because I'd seen in my just routine clinical practice, just by chance, a series of children who'd come into my clinic for diagnosis. So my interest is in rare multiple malformation patterns and intellectual disability syndromes. And I'd seen a few patients over a relatively short period whose mums had all taken anti-epileptic drugs during pregnancy and whom we'd investigated really quite significantly and hadn't found any other explanation for their symptoms. And so one of the thoughts was that this might be due to anti-epileptic drugs, and doing a little bit of reading at that time, basically the only information in the literature were anecdotal case reports mostly. But there were case reports and they were saying the same thing that I was thinking, and that the signs and symptoms of the children I was seeing were similar to the ones that had been reported. So I thought there must be something in this, and actually at that time in 1995 we had a little paper published called fetal valproate syndrome about exposure to sodium valproate in pregnancy. But quite rightly, a lot of other people, when we drew attention to this, said, well, you know, anecdotal reports are not very good level of evidence, and you're seeing a biased subset of children, which we were, because they were presenting with problems to our clinic. So you need to really find some evidence that suggests there really is a problem with anti-epileptic drug exposure. So at that stage, I got in contact with a few other colleagues, my colleagues from Manchester and Liverpool, and we set out to apply for some funding to set up a study so that we could follow children exposed to anti-epileptic drugs in pregnancy right from pregnancy, not just wait and just see the children who'd been exposed and were presenting with problems. So then followed quite a few years of, we managed to get funding actually from the National Lottery to do that. And we made lots of applications to other bodies for funding. But actually, when you're wanting to follow up children long term, a lot of funding bodies aren't interested in that. They want to fund a study where after 2 years or 3 years, you'll have quick results and you'll have a paper. They don't want to wait more than 6 years to fund a study. So we encountered quite a bit of difficulty in getting study funding, but we did set up a prospective study, and with a lot of goodwill as well from everyone, we followed up a cohort of children to the age of 6. And several other studies around the world had started to do the same thing, and so we got to the point where there was enough significant evidence to say that there were problems seen in the children of mothers who'd taken anti-epileptic drugs during pregnancy. Then my own interest, I guess, has moved on to what's the description of these sorts of problems, what are the sorts of problems that children encounter, and what's the natural history of these problems. And I've actually
can I stop you just for a second? So you did the research, it was published, and what year was that?
So 2003, the 3-year-old
No, so it's a little bit later. So we collaborated with some US colleagues. So there's two strands to the cohort. So the first publication was on malformations that came out, led by Kimford Meader in 2006, with a 3-year-old IQ in 2009, also led by Kimford Meader. There was then a paper led by myself on our UK only data in 2010. And then we published our 6-year data in 2015, and Gus Baker was the lead on that paper.
Sorry, and the 2015 publication was?
Led by Gus Baker, and it was on the IQ of the children at 6 years of age.
Okay.
So the difference between our UK study and the American study, which we joined with, is that we also followed up a control cohort of children. So we could compare the outcomes with matched control children, and that gave us a little bit more power to our study. So my work after that has been involved with the natural history of this condition, and I've been able to, over time, follow up children from childhood and into adulthood. We've seen some adults now well into their 20s and see the changing signs and symptoms in these children. And then just more recently, I've been involved in leading a European group which has drawn up some guidance on management of children exposed to sodium valproate in pregnancy, to try and have some expert consensus, even though there's no sort of randomised controlled trial evidence, about the best way to care for these children. So that's the point that I'm at now.
Right, thanks very much. Do you want to take that on?
Yeah, so I guess just to add just very slightly, so I actually get involved in this working on the study that Jill mentions, and that formulated to my PhD, and then we've gone on following that cohort to establish a number of other cohorts, including one that we have at the moment, which is funded by NIHR, so National Institute for Health Research, where the question is less about valproate and is about the other widely used anticonvulsant medicines at the moment, and that's what we've currently got going on.
So I became involved with this field in the sort of mid to late 1990s, and I do recall one of our national dysmorphology meetings where Jill actually, together with her colleague Di, had a set-piece presentation on this condition, fetal valproate syndrome, and there was a lot of unanswered questions, quite a number of pictures of patients, could we recognise them? I have to say at the end of that session I didn't feel I would have very much expertise and be able to do that. But it wasn't very long after that I met a patient, a mother and her child in one of my clinics, and the child had been exposed to valproate and I think carbamazepine, if I remember correctly. And this was a very persistent mother, and I saw her on 2 or 3 occasions, and I realised that there was a significant issue here, and that I had to make a choice between either walking away from being involved or getting a little bit more involved. So I decided to do the latter, and that led to a study which I undertook with my former trainer in Aberdeen, Dr. John Dean. We gathered together a group of patients through the patient support groups mainly, and assessed them, and wrote that paper up in the year 2000. And we combined with that work with our colleagues from the ophthalmology department where I work, and they assess these children's eyes, and a separate paper came out about the visual effects of this problem. And we all recognised that this was a cross-sectional study. It wasn't a prospective study. It was always going to be subject to ascertainment bias. But nevertheless, I think by then those of us who were seeing patients were all convinced that there was a major issue here, and that these patients didn't all have the same set of features for no good reason. And the common thing what was in common for all of them was that they'd been exposed to this drug. So a number of other papers came along as a result of that. I contributed to Dr. John Dean's work in the northeast of Scotland, which was very thorough in the population that they looked at, and I think that was a very good contribution. And at that point, Jill's study, Manchester and Liverpool, was also getting underway and beginning to produce very interesting and helpful data, crucial data, I would say. And in the sort of mid-noughties, I suppose, I also got sucked into the legal case that was being built, that eventually was shelved in 2010. I wrote a lot of reports for that, which brought me into contact with a lot more patients and families, and gave me a much wider, broader clinical experience of the whole area. And partly as a result of that, I also received referrals from outside my region to assess. So I think over the years, I've developed quite a reasonable clinical experience of this, and have contributed as well to Jill's current work with the consensus group, working with the support groups as well. And I think one of the things I'm now recognising is that whereas this particular issue was quite in front of people, in front of our specialty for a period of time, I'm beginning to realise that I think that the sort of expertise level that is there amongst our colleagues has dropped away. And I think that's something which has to, it was a shame, but I mean it's perhaps it's one of those things. And some efforts need to go into re-educating our colleagues as to how to recognise this condition. So I think one of my main thrusts has been really the diagnosis and how to achieve that. I think it's not easy to diagnose, and you can come up with criteria on paper, and if you know that the child has been exposed to the drug, then that's one thing, but then you have to obviously assess the child and to come to a judgment as to whether or not the child's been affected, and that is far from easy because often the features are subtle. So we have a framework for that, but I still think it requires considerable expertise to actually see patients in the clinic and form an authoritative judgment about the diagnosis.
Right. Well, thank you very much indeed. Now, is there anything else you want to say to us before we put some questions to you? It just sets the scene for us, does it?
Sure, yeah.
So, thinking about the past history, thinking about what you've been so diligent in trying to achieve, and particularly your studies and things, do you have any views about the way the regulators have actually taken on this particular issue? Because clearly you found a lot of things that you feel are very pertinent to parents and to the children. And do you think action should have been taken earlier to actually ensure that people were made more aware of this particular problem?
I did have a little think, so I apologise that in our written submission we maybe didn't cover this in as much detail as we covered everything else, but the document got so big and wild, and it's only when we look back over it we realised that maybe we hadn't addressed this so well. I did take a bit of a look at this last week in preparation for this discussion, and I think the overriding issue here, I think, is wider than just regulation. Generally, data took a long time to accumulate, and that was really because we have a very passive post-market surveillance system. So it's based on spontaneous reporting, so alert clinicians writing something up like Peter started off, or flagging it through the yellow card system or the American equivalent or other countries. Or we have researchers who pick and choose based on their interests what they want to look at. And then obviously what funding is available also drives that. So we don't have a very well, and this is still the case today, we didn't have for Valkyrie and we don't today, we don't have a streamlined system, a coordinated system whereby newly licensed medicines are routinely checked at the human level, and whether that be immediately for malformations and other physical problems that are immediately obviously at birth, or whether that's in terms of follow-up. It doesn't happen. We have a very ad hoc system, so data is slow to accumulate. When you look back at what was known with Valkyrie versus how the information sheets changed, I think the wording, from what I read last week, There was some risk information there, but I think it's how it was worded that was maybe slightly misleading or caused confusion. So for example, until 1999, a lot of the data compendium sheets talked about risks with valproate and other anti-epileptic drugs and untreated epilepsy. So actually, if you're a doctor reading that and having to tell that to your patient, there's a lot there that doesn't differentiate valproate, and certainly by 1985 there's very clear kind of differentiation in terms of spina bifida for valproate versus the other anticonvulsants and versus the control population. And I think certainly by 1990, 1991, other malformations there were then kind of limb defects, heart defects. Again, the data was there to show that they were much more prominent in their kind of in the valproate exposed group than other anti-epileptic drugs untreated, yet the data sheets didn't change. It still talked about this kind of encompassing risk across all these three groups. I don't know if you agree with.
I would think that's a major contributor, that they lumped all anti-epileptic drugs together into something called fetal anticonvulsant syndromes. Instead of separating them out. And once we did our study and separated out the different groups, following up children who'd only been exposed to one particular drug as opposed to different combinations, it became clear that there were differences between those groups.
The phenytoin was recognised much earlier, wasn't it?
It was, but its level of trust-genicity isn't at the level of valproate.
No, thank you.
I think it's also true to say that neurologists as a group felt their duty of care, quite understandably, was to treating their patients' epilepsy, seizure disorders, and achieving effective control, which is entirely understandable and right. And sodium valproate proved to be an excellent drug for that. And as a group, they were all more or less doing the same thing. They were all agreeing with each other that this was a good drug. And in many, many cases, there wasn't actually a very effective alternative. But also, they were not prepared to look at the data as it was and come to the conclusion that this was necessarily a dangerous drug for quite some time. So I think in terms of how that would stand up if it ever came to court, all the neurologists were basically doing the same thing, and so they could always back each other up.
And in particular, I think you read the editorials from the time it came. So neurologists were often asked to write editorials covering data that maybe Peter put out or Jill or somebody else. And there was this kind of fall back, well, will other drugs also carry the same risk? But actually, if you delved into the data and like Jill separated it out by drug, the risk of valproate was far superior than what it was with phenytoin, particularly once you get into the higher dosages with valproate. But I think, again, it comes back to research really didn't evolve quickly enough. It wasn't coordinated, whether that be by the regulator or the company or someone who should have had oversight. We were left in a situation where ad hoc bits and methodologies sometimes were poor as well, and so you can see why neurologists sort of had questions.
So we had quite a few really conflicts of interest in the system. So as Peter says, the neurologists wanted to treat the epilepsy in the best way that they could, and were sometimes a little. Well, I've been to meetings where they've been quite hostile about the suggestion. I've had the comment, "You will get a good drug banned," thrown at me in the middle of a meeting. And you can see why they want to treat the epilepsy as best as they can, and they're worried about this situation of sudden unexpected death in epilepsy. And then there was also an issue of not wanting to worry mothers, I think, that came into it. So when people were looking at the wording on the information, people were concerned, for the reasons that for them were valid ones, that they didn't want to put anything on information sheets that would cause anxiety or concern to mothers. If you speak to mothers now, most of them will say, they would have preferred to have known, even if they'd been anxious about it. And that's the one thing I think that upsets a lot of people, that they might have continued on whatever medication, but they wanted to make their own informed choice. And then, of course, there were the interests of the drug companies making the anti-epileptic drugs. And so I think there were many conflicts here all coming together, and we didn't have one system that superseded all of those and took them away.
So are we still in the same position? We're thinking about the next generation of antiepileptic drugs.
I suspect we probably are. Yeah.
So is the one system then? You say you're looking for one system. What would that system look like?
I think in the US now, Christina Chambers, who's at the California Teratology Information Service, they've just proposed a system to the American regulators whereby you use a combination of routinely collected healthcare data, so data mining across different kind of child prescription records, mum's health records, infant records, but along with the detailed direct observational studies that get you the real detail, the ability to control for confounders, the clinician-led blinded assessments. And I think that's something that when we met with the European Medicines Agency earlier on this year, that it looks like that group was proposing to the European Medicines Agency, and hopefully that's something that they will take forward.
Have you written that down? Have you written that
There
down?
is a paper coming out, but it's being led by the European Medicines Agency.
So when can we see it?
We haven't seen the draft since our meeting, unfortunately.
At the time that I was thinking about possibly trying to do a study in the southwest, similar to perhaps what Jill and colleagues have done, I made some inquiries as to how I could find these women who've been prescribed this medication and come through the antenatal clinics and so forth. And I quickly faced a barrier that this was going to be almost impossible, and it was such a huge task to try and overcome that hurdle. And I was a single-handed consultant for quite some time. I just didn't have the wherewithal to try and challenge that, to be honest. So I think there is no system that you can go to in antenatal clinics or in data collection in a public health sense and find it, find these patients.
I think I'm right in saying that there isn't a code either in the International Classification of Diseases or any of the other ontologies that we use that would enable you to go to databases and pick out the cases to follow. And then the other issue is that surveillance, because we're looking, the commonest effects are developmental effects. Surveillance is expensive. Developmental assessments are really expensive to do. If you use a good quality developmental assessment. Part of what Becky's doing at the moment is working out how best to do developmental surveillance, and whether you always need these very expensive detailed face-to-face surveillance or whether you can work from things like parental reports. But that's one of the barriers, I think, and that's what we found with our studies, because every time we worked out a budget for a study that we wanted to do, the budget was massive because we had to put in all this psychologist time, and so that I think has been a major barrier.
I have my sympathy on that. I quite understand. Can I just ask you, and then I'm going to pass to my colleagues, but in the evidence that you very kindly gave us, and I think it's fantastic to have three of you working together as one, it's really helpful. But you mentioned that you're currently producing a consensus guideline document regarding fetal valproate syndrome disorder, which they expect to publish next year, we're told. So you're going to publish next year.
Yeah.
Obviously you can't tell us what's in there because you're going to publish it next year, but can you just say to me the sort of purpose of this and why you're doing it and what do you expect the result to be?
So this was one of the initiatives of one of the European reference networks which have been set up, which actually we're just about to be forced out of. But we have some networks of expert centres throughout the EU, where one of the aims of the networks is to share expertise between different centres, work out best methods of diagnosis and care, and for those diseases which are curable, work on cures. So one of the initiatives we had was to look at how we might better care for individuals who've got fetal valproate syndrome, or fetal valproate spectrum disorder as we prefer to call it now. And so what we did is, in these very rare diseases, you can't find much in the way of randomised controlled trials which tell you whether one way of management is better than another. So what you have to do is get all the evidence you can from the literature, so do a deep literature search, look through all the information there is there, get together all of your experts and get their expert views, and draw together a list of recommendations which you can then grade for how certain you are that they're correct, and then make a list of recommendations for care plans based on the best evidence that you can. So we went through this process. We gathered individuals. When you're doing a consensus document like that, also you need patient involvement. So
Absolutely.
we've had patient involvement because it's no good having a care plan that's not feasible for patients. And so we've been through the process of the literature review, drawing up guidelines, doing a commentary in the document which talks about our evidence for the guidelines, drawing up some revised diagnostic criteria, and then presenting that in an overall document which we're going to publish. And then also one of the things actually that the patients suggested were that lots of patients and GPs don't like reading very, very long documents, so we've also done some supplementary sheets that are sort of quick read summaries for the groups of people like teachers, GPs, paediatricians and patients. So we're just in the final stages of doing that and putting that together, and hopefully we'll be submitting that for publication soon, probably targeted at one of the paediatric journals, because that's where most of the people doing the care will be.
So this isn't about prevention, this is about care.
It's about care. There is a little section on prevention, but it's really only echoing the recent guidelines. Yeah.
And so the patient groups have been absolutely centre to all the
Absolutely, yeah. They've been just as much a part of that group as any of the other experts.
We have learned a huge amount from
Yeah,
patients.
they're amazing. I did a presentation in Brussels last week with Janet Williams. We did a presentation between us, and she was just amazing. It was very powerful.
Thanks. Cyril.
Can I go into numbers, please? Because I'm really confused. I've been told there are 28,000 women who've taken valve-rated pregnancy. I've been told today they think there are 6,000 affected people, children and other in this country who are affected by it. The French say that there's 30 to 40% of between 41,000 and 76,000 children exposed between the start of marketing of their valproate in 1967 and 2016. We know about the IQ effect, and the French also talk about the people who want competence, quite reasonably asking for support. 323 direct victims in utero-exposed children, and 764 indirect victims, parents and siblings. And certainly we've met lots of families where the effects of valproate aren't just confined to the child who's affected, but affects everybody else in the family. And in any case, how do you know that a child who's not seriously got all the features of valproate spectrum disorder doesn't actually have suffered some loss of IQ, for example? So have I explained my confusion? And can you help me?
I think the figure that you started with, 20,000 exposed children,
women who've taken it
over your 40 years, something like that, more than 40 years. That's too low.
That's an underestimate.
On a telephone conference with MHRA last week, they said currently there's about 23,000 women still taking valproate in the country annually at the moment.
Right, okay.
So,
that'll cut that.
14 to 45.
Okay.
Yeah.
So that's okay, right?
So it's much bigger over
it used to be many years ago.
Some time ago I produced a back of the envelope calculation, and it's very difficult to do anything better than that, I think. Based on the numbers of women that we know take anti-epileptic drugs, so that is a statistic that's reasonably hard. You can find that data. And then over the years, valproate's been a very frequently prescribed drug, not quite so much now, thankfully. So you can reach a proportion of those women who are with epilepsy or on a drug will be taking valproate, and from that figure you can roughly work out over nearly 40 years how many women there are who took valproate during a pregnancy, because you've also got data on how many babies were born during that period. And then you can reach, based on a figure of, well, what's the frequency of problems, so at least 10% malformations, but possibly 20, 30 or 30%, and possibly even more neurodevelopmental problems. You then can reach a figure on the number of individuals exposed to the drug who you think will manifest some problem, but it will be a spectrum, so that there'll be.
What is that figure, Peter?
Easily, well, that's the figure that I came up when I did that calculation was 20,000.
20,000.
Yes, and I was encouraged to hear, I think at Jill's meeting in March, that somebody else had done a similar back of the envelope calculation.
Myself and Professor George Moore had done something similar.
And come to a very similar figure. So I was reassured that I wasn't off the wall on that figure.
20,000
effective.
Yes,
and that was from I worked at prescription data from 1994, I think, until 2010.
Yes,
that was the prescription data that came out from.
Cumulatively.
Yes.
And that's working on a 30 to 40%.
Yes, I can't remember which figure I actually chose in the end.
But it's that sort of, I'm only after sort of.
Yeah, so it's taking the spectrum, not just.
Now, how do you respond to what I said? Well, that's who've got the recognised fetal valvular spectrum disorder by experts. But what about these children who've been damaged, albeit less severely than that? And what about the effects of every other child in a family which is necessarily under massive strain and stress? Which the French seem to be identified.
Yeah, so our 20,000 was encompassing those with neurodevelopmental effects alone, not
IQ.
all the physical IQ.
We didn't necessarily factor in the other things we don't need to know about, because a child may well scrape into the average range, for example, for IQ, but may have marked social problems, and that's something I certainly see frequently at lower dosages, is that, again, maybe kind of that, so the social skills, the kind of regulation of behaviour tends to take a hit quite early on at lower dosages, and then you get a hit on cognition, and then you see the structural malformations come in, and that actually is what we predict for terrestrial. You get functional problems at lower dosages.
Sure, but that's not included in your 20,000.
We included IQ, but not other things. No, because we haven't researched them well enough to gain a figure.
I would take the view that the 20,000 covers the range, so that the proportion will be very easy to diagnose by nearly all of us. And at the other end of the spectrum, they'd be far more difficult to diagnose, and their effects would be relatively minimal. And actually teasing out whether they've got damage due to exposure to valproate, or they come from dysfunctional families, or some other problem, might be very, very difficult.
So one of our key roles as clinical geneticists is to exclude other causes. Because that's really important, that we've made sure it's not, another reason for the neurodevelopmental effects, because there is no specific diagnostic test. There are people looking at diagnostic tests, and there is definitely research going on, but at the moment we don't have a blood test we can do to say you've been affected by valproate in utero. So it's a diagnosis of exclusion, and we have to factor in that for every child who comes to our clinic where we make that diagnosis, we've also done a detailed chromosome test, maybe a Fragile X test, and any other tests we think are indicated to rule out other possible causes.
Because we've met families who have ascribed other problems they have to valproate, hypermobility for a start. But we've also talked to your colleagues, geneticists, who say, well, that's not actually part of it. But we've also heard about other musculoskeletal disorders that they think are part of that valproate. So in the document you're producing, would you deal with that?
Yeah, so in the document we've produced, we have, in our diagnostic criteria, drawn up criteria which are essential to have, criteria which are very suggestive, so you would find these significantly more often than you would in the general population, and criteria which are supportive, and we've divided them into those categories with a scoring system, and part of the essential is that you've ruled out other conditions as well.
And my final question is, just to reassure everybody, just my final question. We've also been told by families of their continued concern about a person with valproate passing it on to their own children, and we've also been told very reliably that's not possible.
Certainly intuitively, it's not possible. I mean, I think we always have to keep an open mind as to whether there's some mysterious epigenetic, factor or something like that. But the fact is, at the moment, that the research has not been done, and it's waiting to be done.
But as a geneticist, you can't perceive of a way. It doesn't fit our models.
Evidence at the moment, but I think we covered that in our. There's one paper in the literature in an animal model, which suggests an intergenerational effect, not for the malformations, but the autism spectrum phenotype. But that is one animal model. It's not been replicated. It's not been done in humans. So at the moment, we would say that there isn't any evidence. However, it still needs to be researched, because you can alter your genetic makeup by environmental factors. So that still needs to be researched, but at the moment there is no evidence.
Thank you, that's very helpful. Thank you.
Right, Simon.
Yes, a couple of questions, if I may. There was one thing that you said, Professor Turnpenny, at the beginning, which was kind of intriguing. Well, there's several things you said that were intriguing, but there was one that stuck out, which was, you said that the level of expertise among your colleagues has fallen away. And I assume you mean recently or over the years. I just wonder if you could elaborate a bit on that and as to the reasons why.
Well, some years ago I ran a study day to which some of our colleagues came, and I think the problem was flagged up at these national meetings that we would go to. But I think that after a few sessions you would assume that everybody's got enough knowledge there, so it wasn't terribly exciting to bring a new case to show to these groups. And many of our colleagues who were part of our community at that time are actually now retiring or retired. And I think the group of the next generation of clinical geneticists coming up behind hasn't benefited from those sort of closed sessions and in-depth sort of discussion sessions we had around this topic that we had at that time. So I think that needs to be revisited, would be my view.
I think the training has changed. The way we train has changed. Yes. Genetics has really grown as a subject. So many geneticists used to be focused on these rare malformation conditions, and that was their bread and butter. Now you do cardiac genetics, cancer genetics, neurogenetics, and you only do a very, very small part of your training on the rare malformations and paediatric genetics, and in some centres you do very little, and so I think it's a reflection of that.
And a huge emphasis now on how to interpret DNA findings, what we call the genomic era, which has added a whole new level of training needs.
Right. So what are the implications of that for the diagnosis of FESD in the future?
Well, I think they're very considerable, and not just this condition, but others.
Diseases,
actually,
yeah.
Others, yes. And there are efforts to try and make this whole process easier. Various, computer programs and expert resources. But actually, in response to, I wanted to comment on something you said, Mr. Cyril, that there's actually no substitute for seeing lots of patients. And when somebody says hypermobility is not part of this, I would challenge that, because some children are hypotonic and have hypermobility, and you can recognise a similar posture that some of these more severely affected children have. And
so that's not genetic, that's
clinical, that's good.
Clinical.
Yeah.
It's more a direct effect.
Yes.
Okay.
So in other EU countries, because the French have done quite a lot of work on fetal valproate syndrome, in other EU countries, the way that they've addressed this rare disease expertise is that they have set up networks of expert centres in rare diseases. The French have a particularly well-developed one, where they have about 8 centres in their country which are really experts in rare disorders, and they train and develop expertise and have a lot of patient involvement too. And that's how they have maintained their clinical standards, I think, because those centres work really well. But that's perhaps what we're lacking a little bit here, is that we need some
And you would
centres of
support that, because we've been
expertise.
thinking about that, because we did that for end-stage renal failure. Manchester's one of
Yeah.
I mean, to add to that as well, neuropsychology would be the people that would assess brain functioning in this are incredibly rare. You know, you tend to have paediatric neuropsychology teams in only major neuroscience centres, so you're talking your major children's hospitals throughout the UK, but they tend to be funded for specific things. So for example, epilepsy, brain injury, metabolics. You have very few people who would be able to assess a child with fetal valproate syndrome, have experience to bring to that assessment to match the profile. Does this profile make sense, or is this something else that's going on here? And so to add to the kind of the difficulty and challenge around clinical geneticists, I think we also need to think about the wider team as well that would be needed for diagnosis. Would you agree?
Oh, absolutely, definitely.
Could we extend the scope to deal with other possible effects of drugs in pregnancy? Because
Absolutely.
Yeah, it's the same skill set really that
Yeah.
you use. Yeah.
Could I change the subject and talk about registries? Because there's a lot of thinking around registries in relation to, well, at least two of the three areas that we're looking at. And I wanted to just ask you your thoughts on how important it is to have a registry, whether there's one already in existence for valproate, because I understand there is a UK epilepsy and pregnancy register, which we've struggled to find out much about. So if you knew anything about
I'm
that.
on the committee if that's
Right, so you might be the right person to ask about that. But how important do you think it is for there to be a registry, and is that the basis on which we could start to build one?
And I think registries are set up to answer different questions. So the UK Pregnancy and Epilepsy Register is women who are recruited while they're pregnant on any anticonvulsant, or actually not on an anticonvulsant. Actually, we have a control group as well. And that was established by Jim Morrow in 1996 and has really contributed a huge amount of data to our understanding of the risks associated with valproate and some of the other anti-epileptic drugs. We have similar registers again for women with epilepsy in North America. The Australian register has been very successful, and more recently we've had a collaborative European approach that now actually extends past Europe and includes data from India and Australia, and that's called EURAP, and we did reference those in our submission. So the registers there that are to generate data predominantly on malformation outcome for women, they work very, very well. And what we see is that the disease-specific ones have worked a lot better than the pharmaceutical ones. So certainly a lot of the US-based pharmaceutical companies over the last 10 years set up their own malformation register at the request of the FDA, but actually they methodologically weren't brilliant, to be honest, and didn't really recruit very many individuals, and their comparisons to control samples were a little bit limited. So I think the disease-specific registers for generating risk data work very well. They aren't greatly funded, they struggle, which is a narrative obviously you've already heard from us. Moving forward to what you would do valproate specific, I know the MHRA are currently looking into this. I was on a telephone conference with them earlier on last Monday about that, and they seem to have an idea about tracing valproate use, but also following it through to the longer term outcomes of individuals exposed to valproate. Not 100% clear how that they were going to do that, but it's in the very early stages, and it's certainly something that they've got planned. Registers, if they are nationwide, can be challenging to get around to see everybody. That is a downside of them, no doubt, but actually here in the UK, because our geography is quite small, we are actually quite uniquely placed in many ways to do the longer term follow-up within registers, and certainly we've done a couple of follow-up studies now with the UK Pregnancy and Epilepsy Register, where myself or we've had junior staff who've gone out all over the country collecting this data, and obviously in comparison to North America it's a lot easier for us to do that. So I do think we're well placed. There isn't currently a register for fetal valproate spectrum disorder or fetal anticonvulsant syndromes, is there? I think we all hold our own little databases, but there isn't a register per se.
Yeah. The only register that I know of within Europe is that there are a group of fetal anticonvulsant patients within a register system called Genida, which is run from Strasbourg, where patients actually enter their own data into the register. And they have a cohort of mostly French fetal valproate syndrome patients.
How comprehensive is the register here, the one that you're sitting on the committee of?
The UK Pregnancy and Epilepsy Register, so it gets reports from the GP at 3 months as to the physical health of the child. It doesn't go any further than that due to funding reasons.
And it's only certain centres though, isn't it?
Yes, so it's not it's majority of women opt in, or as Peter says, certain centres will say to women, there's this register running, you might like to kind of take part. And then more and more I'm trying to then ascertain separate funding to go out to answer a specific question. So for example, we answered one around valproate and levetiracetam in 2016. We published that data, and currently I've got a student project that we're working to set up at the moment on topiramate. But again, I guess back to kind of what I said at the beginning, it's all very ad hoc, it's all dependent on what we've got time to do, where we can get money, where we can access the populations. We would love to be able to follow every woman up who was enrolled on the register. That would be our dream.
But you're talking about following them up once they're on the register.
Yes.
My question is, what proportion actually go on the register?
Sorry,
is it triggered by the women and then the GP put in?
It's very variable. It's certainly dropped. I don't know the numbers. It's certainly the last sort of 5-10 years we've seen, as clinicians have become more busy and aren't entering women themselves, the kind of the numbers that are recruiting have dropped quite substantially.
It's the obstetricians also who were the main people entering patients onto the register. And again, I think it has dropped. We run registers for many rare diseases, I guess, and the ones which work best are the ones where someone gets something out of the register. So it's either a research register or it's an NIHR funded portfolio study or something which you get accrual figures for entering all your patients onto the register. So if it's all completely voluntary, it's not so easy to maintain.
I understand that, yes. Sonia, is there anything you want to ask? I'm sure Sonia will come back to you in due course. But anything else you finally want to tell us, because we're just up to the time limit now.
I think one thing that I'm concerned of, just with my contact with families over a long time, is that this is all, fetal valproate syndrome has been seen as like a paediatric disorder, but now we're seeing the adults come back to clinic and they have got problems. And most of the adults, well, I think virtually all the adults, they come back, they're in their mid-20s, going up to 30, they're still coming back with their parents. They're struggling with getting a driving licence, with being able to live independently, with managing money, so practical skills. And so I think we still have a lot of work to do in actually finding out what the long-term implications are.
We certainly see these regional, I can call them that, centres as being very much multidisciplinary, covering the whole age spectrum, but also other skills like social advisor and care pathway navigators.
And I think it's also, my observation is that some of these young people have been through further education even, with support very often, but actually leading independent lives in the normal sense is really a struggle for them. So at one level they appear to be doing okay, but actually when you try and put them into society to function
and the state
independently,
benefit system doesn't work for them.
No, they fall between the gap, absolutely, yes.
Yes, we've heard a lot about social isolation, and that they haven't been able to lead normal lives, get married, all the rest of it.
And
so anything else, Professor Bromley?
I don't think so.
Dr. Bromley, who made you a professor?
Yeah, thank you. I guess just one comment is that I think it's worth saying that this is not a situation that is, the lack of knowledge and the slow accumulation of data is not specific to valproate, it's not specific to the anticonvulsants. To be honest, we probably know now more about the anticonvulsants than we do about certainly the neurobehavioural tragicity of most of the drugs. We have data from the US that when they looked at the time it took on average to determine teratogenic status, it was 27 years. And that was based on malformations. If we were looking at the impact on the brain, we could probably double that, if I'm honest. So we have a huge system failure really within medicines. It's not just specific, but unfortunately valproate has been the first major teratogen, I think, to hit this kind of ad hoc system and really show its inadequacy, unfortunately.
Oh, thank you so much. Thank you very, very much. I think that the parents and the children and the young people and the 20-year-olds and plus are very lucky to have you taking such an interest in this subject. So thank you very much indeed.
Thank you.